Hello and welcome again to another edition of the Osteopathic Lyceum podcast. I'm going to go through some concepts that I would call the fundamental deals of osteopathic manual therapy and education as well. So first, say as the foundation, the absolute foundation, I want to note that the end user of any healthcare practitioner skills is the patient or the person, whatever term you want to use, that presents to gain care from that healthcare practitioner such that they will benefit from the skills and knowledge that that healthcare practitioner has for their own health, right? So the patient is going to benefit from the knowledge and skills. So all things in any form of healthcare practice or healthcare education should work backwards from the end user being the patient such that their health improves or gets better having had the interaction with the practitioner. So we have to keep that in mind as bedrock. Medical ethics guide us in how we choose to interact with the patient with respect to the skills that we gather. So your medical ethics being beneficence, beneficence, essentially doing good for the patient. Non-maleficence comes before that. Non-maleficence is primum non nocere, first do no harm. So any choice that you make as a healthcare practitioner, you should have an exceptionally high degree of confidence that it will not harm the patient. After you know, or you have an exceptionally high degree of confidence that your intervention will not harm the patient, it should also benefit them. So beneficence comes next. Autonomy is there as well. So the patient should be free to say yes or no to any form of intervention. They should be free to say yes or no with as much information as possible. So you're talking towards informed consent. Informed consent has arguments around it that suggest it's never really truly possible to gain truly informed consent because the patient may not be in a position to understand enough of the information, enough of the pros and cons in a complete fashion compared to the actual practitioner. And even the practitioner may not know things about the actual intervention that would be pertinent. They may know how to do it exceptionally well. They may know its general risk profile, but there may be some things that they don't know. So it's actually hard to get what one would claim in a philosophical sense, fully informed consent, but you can get really close. Anyways, autonomy is the patient should be free to choose to accept intervention or deny intervention in as informed a way as possible. Then you have justice. Justice may be better termed triage, such that you are attempting to provide care to those who are at greatest risk of having harm done by not receiving intervention now. So let's just say you're in a catastrophic situation and there are 10 people. 9 of those people will die in an hour. 1 of those people will die in 5 minutes. You provide care to the person who's going to die in 5 minutes because the people who may die in an hour have more opportunity to wait for the care, where the person who's going to die in 5 minutes, and this is a hypothetical situation, but the person who's going to die in 5 minutes needs it now. Essentially, that's a really, really rough way to talk about justice or the application of justice with respect to classic medical ethics. So that's a choice-making framework for how you interface with a patient. So we know that our skills have the end user as the patient. We know that we should put it through the filter of medical ethics or healthcare ethics, whatever term you prefer. Then we have to go to educational institutions. So educational institutions are now essentially in a position where their fundamental assumption is that they need to prepare people as practitioners to get the skills delivered to the end user filtered through medical ethics. Please excuse me, it's getting cold up here where I live, so I got some funny stuff happening. Anyways, and hopefully it doesn't mess with the audio experience too much because often my throat clearing does that. So the educational institution has to or should make the bedrock of the deal they are going to provide to the learner that they're going to help them apply their skills to people who are seeking help from them in a way that doesn't harm them, that benefits them, that allows them the ability to communicate with the patient such that they can have enough information to say yes or no to the intervention, and that they should provide that intervention to the person who needs it most now, as opposed to somebody who can wait, as a really, really rough framework. So that's the bedrock. We've got to do that. We absolutely have to do that. What the person as a learner does with that skill set that the educational institution delivers to them has the opportunity for a variety of expressions. So you can't necessarily, even if you test people appropriately, guarantee that they're going to do what you taught them to do or going to do it in the way that would be most ideal. There's going to be variation in outcome there. So that then allows us to turn to the next layer. So the absolute bedrock of the deal that the school is striking with the learner, the soon-to-be practitioner, is that they're going to be able to deliver skills to somebody who's seeking some kind of healthcare intervention in a way that will not harm the person seeking those skills, will benefit them, will allow them to say yes or no with as much information as possible, and they will receive that care in accordance with how soon they require it. That's actually one that's hard to do, to actually triage appropriately, especially with a scheduled healthcare practice, as most hands-on practices are. You have time slots, people are going to show up for them. In order to bump somebody for, say, to a particular time because of urgency is less likely to happen in hands-on manual therapy. It doesn't mean it never will, but it's less likely. Usually the battle that you're going to have with respect to scheduling is somebody who wants a particular time slot on account of the fact that it is their preference. So that doesn't necessarily require one to consider the concept in classic medical ethics of justice. So anyways, we've got that covered redundantly, because I tend to repeat myself on purpose so that there's more than one way to gather that information, to connect with that information. Now, the next part of the deal requires us to consider the difference between publicly funded and privately funded education. Privately funded education, the deal that the school is striking is that you're going to have the skill outcome that we talked about, the ability to apply a skill to somebody seeking treatment or intervention through the filter of medical ethics appropriately. So that deal is the same whether it's a publicly funded or privately funded institution. The privately funded institution is more of a deal between the individual student and the educational institution, that they will get those skills so that the individual student can apply those skills as they choose, where they choose. A publicly funded education has a very, very different deal because there's other people involved in the deal. If you receive public money, what that means is that you are now on the hook to produce people with the skills you say you're going to produce. So in this case, to be redundant, people who can apply their skills as an intervention to those seeking it for healthcare purposes that will not hurt them, that will benefit them, that they will be able to say yes or no to with as much information as possible, and that will be applied to them in a fashion that is related to how soon they need it. And how soon they need it is a nice gray area, as we already talked about. Okay, but the other part of the deal with public money is that you're supplying that to the people or to the constituents who are giving you that money. So whatever jurisdiction you're in, whoever that tax money is received from, they are expecting the school to produce that outcome for them. They are not expecting, if I use Canada as an example, they're not expecting taxpayers in Ontario to provide a practitioner for people in British Columbia. So it's a really simple jurisdictional thing. Whoever you get the money from, whichever constituents you get the money from, they're expecting that you return the skills that that institution generates to them, not to ship it somewhere else. So we get to a really interesting thing where we can have a discussion that maybe somebody from Vancouver or somebody from British Columbia wants to move to Ontario and work in Ontario. Therefore, if they have some fundamental agreement that that's what they're going to do, then the entire Ontario taxpayer probably feels reasonable about that. Or the Alberta taxpayer feels reasonable about somebody coming from Nova Scotia getting trained in Alberta and working in Alberta. We have to remember that the fundamental deal is between the people who pay and the people who produce, right? So in a private institution, the people who pay are the students themselves. So the students themselves expect that they can gain the skills, the appropriate skills required, and go apply those skills where they see fit. Where a publicly funded institution does receive some money from the individual student, but they also receive money to subsidize that education to some degree from the general public in the region. Therefore, the general public in the region has a vested interest in the outcome being applied to them as applied to other places. Now, a way in which you can see this play out is if a jurisdiction has residency requirements, or they have requirements of people when they're finished working in that region. Now, there's lots of discussions that can be had there, pro and con in all directions, but I think because of things that I have to pay attention to, things that matter to me teaching others, as a private institution, I should also be aware of the responsibilities of a public institution. Now, in most cases, most people are going to end up working relatively close to where they go to school on account of the fact that they probably live relatively close to where they go to school. Obviously, that's not an exclusive thing. Some people are much more willing to travel and much more able to travel, so they can go to school wherever they feel like and then go work wherever they feel like. Another thing that gets involved here is that you will find, if you look at the requirements to work in a particular jurisdiction for anybody in any profession, it is much easier for them to trust and validate the education matching the requirements of that jurisdiction if the person was trained there. Because the private institutions or the public institutions are likely to gear the specific pieces of information that they teach their students to the jurisdiction in which they are operating. So if you're operating in, say, New South Wales in Australia, if there are unique regulations in New South Wales in Australia, as an educational institution in New South Wales, you will follow those regulations. It is unlikely that you will follow the regulations that may apply better to Dortmund, Germany, as an example, or Nagoya, Japan. Like, you're probably not going to know those regulations exceptionally well. You're probably not going to gear your education to that. You're going to gear your education to the details of the jurisdiction in which you're operating. So that actually ends up becoming an accidental restriction in some cases on where an individual student, when they graduate, can work. Now, if you abstract a little bit more, and you find some way, depending on the particular skill set that you're trying to teach, or the particular profession that you're trying to teach, you can gear your education so that the person can work wherever. If you're in a profession such that that's possible, then you can do that. But it's not the easiest thing to do. So it is very, very important that educational institutions end up having the opportunity to be clear about the jurisdictions and the regulations and things like that, so that they can then provide that information to their learners. Keeping in mind that also it is valuable for an educational institution to acknowledge where their money comes from, such that they do a better job providing the outcome deal that the learners and the people involved in paying are assuming that they will get. So that really applies a little bit more to the public sphere. Anybody who receives public funding, whatever form of public funding that is, the expectation is that the student who graduates will work in the jurisdiction that provided the public funding. I'm in Ontario. If I receive public funding, then I would expect that the learners would end up working in Ontario and they would not move around. Whereas a private institution has a better opportunity to prepare people to move about varying jurisdictions as long as it's possible and as long as they understand that to some degree. So the reason I primarily wanted to speak about this is because in osteopathy, depending on where you go, There are going to be public institutions, private institutions. There are going to be a variety of regulations in varying jurisdictions. And then you end up seeing things within the sphere of osteopathy, like the WHO document for benchmarks and training in osteopathy, like the CEN and CSA documents that are guiding education. Those documents, while coming from a place of good intention, have done what I think is a bad job of acknowledging the variation in jurisdictions and what the actual outcome of osteopathic education should be. Sometimes they just think about what has already been done and what they feel like is important, as opposed to what can be observed to be important. Osteopathic practice is a hands-on manual practice, regardless of what anybody would like to say. If you observe what is done and how it is performed across the board, regardless of the stories that are told, we assess movements, we treat movements, and to whatever degree any sensation that we cannot identify, because I cannot identify a sensation in another person, I can identify proxies of that sensation and have no opportunity other than to trust that how somebody describes a sensation is what they're feeling. Maybe it is, maybe it isn't, but I have no choice but to trust that because I can't actually sense their sensation. I can sense proxies of their sensation. So osteopathy is a movement-based assessment, a movement-based treatment, a movement-based reassessment. There is no assessment of sensation other than communication, which is imprecise between humans. So the fundamental skill set that will allow an osteopathic practitioner to not harm somebody looking for intervention, to benefit somebody looking for intervention, to make sure that they know enough information to say yes or no to the intervention, and to apply that intervention in a timely manner based on needs, is going to be the hands-on manual skills. It is not necessarily the stories that are told in relation to it. This all ties up nicely because my suggestion, my argument is that the schools be extra cautious about the stories that they tell the students. If you tell classic osteopathic stories that are observably incorrect with respect to how they represent how things actually function or how things actually work with hands-on treatment, then they are actually, in a lot of cases, making it harder for the patient to be as informed as possible. The patient is going to receive a movement-based assessment that can tell them things about movement quantity and quality, not necessarily internal function. They are going to receive a movement-based intervention that is going to alter the quantity and quality of that movement, and then they are going to receive that reassessment. The ability for somebody to interpret and say that a particular internal function is doing a particular thing on account of that hands-on external assessment is very low. So I would argue that in order to satisfy the fundamental deals of educational institutions, in order that the graduates can apply treatment to the end user in a way that doesn't hurt them, in a way that benefits them, in a way that allows them to say yes or no based on as much information as possible, and that as much information as possible is, I'm looking for movement restrictions, I'm going to change the movement restrictions, you will feel how you feel, then provide that in a timely fashion. It would be very beneficial for us to move away from a lot of the classical osteopathic stories. There is a lot written about this. There is a lot of research that seems to point in a similar direction that would support the argument that I'm making. So hopefully anybody interested in osteopathic education has listened thus far, or this far, and can take some of that on and understand that you want to work backwards from the outcome goal, which is the application of skills as an intervention to those seeking it that will not harm them, that will benefit them, that will allow them to say yes or no with an appropriate amount of information, and to receive it in a timely fashion based on needs. And needs, especially compared to others with similar need. So thank you for listening this far. Hopefully that made some sense to you. Hopefully you took something positive away from it, and we'll talk again soon.